So you can see in this case that a patient in third trimester had visited us, as I just told now. She was 7 to 8 months of pregnancy, okay, and she had severe respiratory difficulty. She cannot lie down, okay, because her floor of the mouth was completely elevated, as you can see in this picture. Just before this slides, I just shared how important is to treat this patients, odontogenic infections, especially during pregnancy at an appropriate time. Okay, so dental evaluation has to be done before pregnancy to avoid any unfortunate events. So this patient had severe difficulty in breathing and unable to lie down. Okay, she just completely sits up. So we had to do nebulization and awake fiber optic intubation, which is very, very important to avoid any rupture of the abscess. Okay, so this is a typical characteristic features of Ludwig's angina, okay, where there is a lot of collection, and we had to do a fetal ultrasound to look at the status, and it has clearly indicated that child was having bradycardia. Sorry, the neonate or the fetus was having bradycardia. So premature delivery has to be carried out in the 7th month, okay, by C-section. So fiber optic intubation was carried out, and then you see that bilateral submandibular incision and submental area incision markings, and we had drained around 250 ml of pus, okay, with complete debridement, and we have placed the drains. Even intraorally, we opened through the sutures incision sublingual area. Okay, all dependent drainage has been done. But post-operatively, patient has never improved. Okay, patient has never improved even after 4 days after incision and drainage and IV antibiotics. The infection has spread still further because we were not able to take the CT scan because of the pregnancy and emergency scenario. We had to do the C-section. And post-operatively, we have taken CT, and it is clearly indicating, as you can see in this CT sections, that it has gone to the retropharyngeal and parapharyngeal spaces. Okay, you can see the air pockets within the pharynx, as indicated by the arrows. So patient was again taken for surgical drainage, incision and drainage. Now cut throat incision is given. As you can see in these images, see this whole pus is drained and there is a pharyngeal gutter. As you can see in this, the pus keeps pouring out. Okay, and most importantly here, the odontogenic cause which was there was also removed. Okay, the source of infection was also removed. So it is very important to have a proper follow-up of the patient and completely evaluate. And always debridement post-operatively, we have to do at least 3 to 4 times in the first 3 to 5 days. We will know the status of the patient. Okay. However, still further, even after the second surgery, the patient was not improved. Still pus was pouring. So this time, this patient was taken for the third time to the OT. The infection has spread to the mediastinum, as you can see in this, into the middle mediastinum. Okay, so we had to take help from the cardiothoracic surgeons. They have opened in the supraclavicular area and they have dried and placed drains. Finally, after 35 days in the hospital, she has recovered and she was ready to see the infant for the first time after almost a month. Okay, so this case clearly signifies that's which have been insisting that any odontogenic infection during pregnancy must not be ignored, stating that it can be taken care after delivery, after post-pregnancy. So there was a case immediately post-pregnancy, because of the hormonal changes or the physiological changes, the high chances that they might succumb to further deep neck spaces from the simple odontogenic infection. So we'll regarding next complication is a cavernous sinus thrombosis, where we will be discussing one case scenario here also. It is purely a complication of epidural or subdural, but however, infections from the tooth, okay, or paranasal sinuses, or from the face, it can go to the cavernous sinus. The cavernous sinus has mainly ophthalmic components, that the nerves, cranial nerves 3, 4, and 6. And also the internal carotid artery is also present, which passes through that sinus within the sphenoid bone. So you can see the way the infection can easily spread from the face from the anterior spread or the posterior spread. From the anterior region, from the angular or superior inferior ophthalmic veins, it can easily go to the, from the danger area of face to the cavernous sinus, as you can see in this image. From the posterior route, that is from the infratemporal fossa, pterygoid venous plexus, it is connected to the cavernous sinus, as you can see in this, through the emissionary veins. Okay. So normally these patients present with headache, severe headache, and also typical ophthalmic findings. Okay, periorbital edema, chemosis, and ophthalmoplegia. That is, all the cranial nerves get paralyzed, especially the orbit or the third cranial nerve, fourth, and the trochlear and the abducent cranial nerve. Okay, the pupillary response also becomes sluggish. The management of this patient is typically culture and sensitivity based antibiotics, and the antibiotics which cross the blood-brain barrier. The surgical management is nothing much we can do about it. It is to remove the offending cause. The source of infection must be removed. Okay. The typical the management aspect, sometimes if a thrombus is clearly evaluated in the CT scan, we need to give anticoagulants like heparin to the patient, and also corticosteroid to reduce the inflammation. So surgery is technically difficult, but along with the neurosurgeons, it can be done. So this is a small case scenario where, because of a odontogenic infection, you can see in the left quadrant, the third molar periapical infection, this patient never had much trismus, no much clinical features, but eye signs he has developed. Okay, you can see in that. He had almost complete ophthalmoplegia with paralysis of the oculomotor, trochlear, and abducent nerves. Okay, so simple odontogenic infection can also cause easier spread even in a healthy individual if it is ignored. Okay, we need to keep a notice. You see, this patient had a small pistule opening in the cheek. Okay, she went to a local village medical therapist, where they have used heated rod to treat the pistule which has come open from the odontogenic cause. When we visited, she had a very bad periodontitis and grossly decayed molars. Okay, so typical odontogenic infection. So the time she presented, she was not completely oriented, and you can see the swelling and also see the necrotic tissue present. She developed even the necrotizing fasciitis. Okay, you can see in these images, and also typical signs of cavernous sinus thrombosis, which you can see in the CT scans. Okay, within 1.5–2 days, she reached us. She didn't survive and she expired. So a simple odontogenic infection spreading to the meninges or to the cavernous sinus is a typical example not to get ignored. So this is my last case scenario, where you can see this patient walked into the OPD with severe restricted mouth opening and dumbbell swelling. So we suspect it to be a what space infection? It can be a temporal space, right? Or infratemporal space, because patient has a trismus, one of the masticatory spaces, and also clinical features typically suggesting the same. And it was painful. This patient has, when we evaluated clinically, there is no decayed tooth. Only history gives that he had a bone piece which he has bitten on the molar and the root fracture happened. That is all he says. Okay, and there was a crown fracture, vertical fracture in relation to the 1/7. Okay, there is no other history which is present in this patient. You can see this typical dumbbell shaped or the temporal space swelling and some swelling around the eye. So CT depicted there is no collection as such, but cellulitis. As I said, cellulitis is always a sign if it is diffuse or if the patient is having trismus. It is very, very essential to do a decompression. So we plan to take this patient on emergency basis. However, we have sent a few blood investigations. As we didn't identify any odontogenic cause directly related to this, because a simple vertical root fracture cannot cause this infection, we have sent for blood culture also. However, blood culture was taking more than 48 to 72 hours for the report to come. So we have taken this patient under GA for decompression because swelling has increased by second day after coming to us and after even starting antibiotics. You can see in this image, the swelling is completely increased. Okay, and you can see typical dumbbell shape now. It developed a buccal space and also the temporal space, which is clearly evident. Even the upper eyelid is involved now. Okay, it's not able to open the eye. On other lab investigation, we came to know that he is undiagnosed diabetes. Okay, uncontrolled diabetes, and for the first time he was diagnosed. His glycolated hemoglobin is more than 10. Okay, and fasting blood sugar is more than 200. And that which is managed from the last 3 months, which glycolated hemoglobin it clearly indicates. Okay. So the blood culture, to our surprise, it has come as, Burkholderia pseudomalae. That is nothing but it causes melioidosis. It has nothing to do with odontogenic. Okay. So the patient was taken over by infectious disease and patient was isolated. This melioidosis is very, very, very rare that it causes infection in the head and neck region. But however, cases are reported. He was by occupation farmer. Okay, it is more common in the agriculture. In Asian countries, it is more common. Okay. So after 3 days, after we have done IND, patient developed multiple vesicles on the face. Okay, and we have sent for virology testing and it has come positive for Bacillus zoster. So now this patient has a space infection because of the melioidosis, okay, bacterial infection, and also has a viral infection also, herpes zoster. So within next few days, within 7 to 8 days, wherever those vesicles are there, when we examined in the isolation ward, the pus was directly draining through. Okay, you can see this. And this patient, all high-end antibiotics were going on because all the empirical antibiotic therapy, that is your Augmentin or amoxicillin, gentamicin, all were resistant. And he was only sensitive to few of the cephalosporins and carbamidins. Okay. So the pus was completely draining to the multiple vesicles which were there. And we have repeated the CT. And you can see that now clear-cut accumulation of the pus. There is a lot of collection in the temporal region, infratemporal, submandibular, even medially along the parapharyngeal space. Infection has gone under the deeper to the neck, okay, in the deep neck spaces. This was in the morning, and the patient, by the time we took the patient under GA by evening, okay, the patient developed necrotizing fasciitis. You can see this darkening of the skin all around. Okay, this is called necrotizing fasciitis. Okay, complete necrosis of the Gordinsky space number 1, the subcutaneous tissue. All the fat plane subcutaneous tissue is necrosed. Okay. Now you see in this, we have treated with 36 days of meropenem and cephalosporin for 14 days, and various antibiotics therapy were done along with the wound debridement, okay, of the necrotic tissues. See, this was on the post-op day 1 after the second OT, day 14, and after 40 days, is on regular follow-up now, is out of the hospital. The whole areas are healing. Some amount of granulation tissue still happening with the scarring, but however, systemically has improved. Okay. And on ultrasound of this patient, he had systemic melioidosis. Even he had a splenic abscess also. Okay. So the well as accepted risk factors for melioidosis is immunocompromised status, which we discussed previously, like uncontrolled diabetes or renal diseases. Okay, this infectious disease is mainly caused by the microorganism called as Burkholderia pseudomalae. Okay, it is also, that's what this condition is called as melioidosis, also called as a Whitmore's disease. Okay, this is a very rare infection. As per the World Health Organization, it is a red flag whenever we encounter this infection. Okay, because there is no vaccination for this, okay, infection, and it is very difficult to treat. It requires a long-term treatment. So the gold standard for diagnosis is purely culture. Okay, especially microbiology and blood culture is the gold standard. So this was a very, very difficult scenario where this patient walked in, which we thought it is an odontogenic cause, but within 2 or 3 days, the scenario, whole thing has changed. Okay, so it has become a septicemia with milidiosis, causing multiple organ abscess, okay, and causing necrotizing fasciitis of the head and neck region. Okay, however, patient improved with intense antibiotic therapy and regular debridement. So the management of this condition is usually antibiotic therapy, which involves in the acute phase and also in the eradication phase. So to conclude my presentation, the take-home messages is never consider this maxillofacial space infection to be neglected, and should be treated at the earliest. And most important is to remove and identify and to eradicate the source of infection, whether it is a ear infection or it is because of the odontogenic, whichever teeth, third molar or any decay teeth or periodontitis. Okay, and the choice of treatment for abscess is always incision and drainage. The drug of choice, you can tell it as a blade. Okay, so abscess, it requires drainage, because whatever antibiotics you give, the abscess it will not reach the abscess cavity, because abscess is walled off. Okay, it contains only dead blood cells, okay, and dead bacteria, white blood cells, everything are dead cells. Okay, it is clearly walled off, so antibiotic will not reach. The choice of treatment is mainly incision and drainage, the blade. And we must always start empirical antibiotic therapy with much importance to the culture and sensitivity. And also sometimes if we suspect the patient is not improving, okay, with simple antibiotic therapy, even after incision and drainage, even blood culture also has to be done, okay, without ignoring that aspect. And follow up with signs of recovery. We need to see the fever has to come down, the pus discharge has to come down, the mouth opening has to improve. Okay, all these findings are very, very essential in the follow-up of the patient, whether in the OPD basis or in the inpatient setting. Thank you very much.
Yeah, thank you very much, Dr. Srikanth, for the elaborate discussion on odontogenic space infections. So I hope it was very beneficial to our students. Okay, so
thank you.
Yeah, thank you. You had taken so much of time in showing the clinical scenarios of the cases reported in your Manipal hospital. So really good for all of us. Dear Srikanth, one question is there from my side.
Yes, please.
If there is a medically compromised patient who is on antibiotic therapy for a space infection, and it is due to a probable tooth which is causing it. Now, can we extract it during the during the course of antibiotics, or do you feel that once the whole infection should be controlled, then only it should go in for extraction? What is your take?
Yes, if the patient is medically compromised, diabetes or uncontrolled diabetes, for example, very most common scenario, okay, it is always better we do the treatment under antibiotic coverage, but the source of infection has to be removed. Okay, unless we remove the source of infection, maybe the patient is completely compromised with uncontrolled diabetes or as such. Even the sugar control cannot happen unless we drain the abscess. Okay, even abscess can also cause stress. Okay, a lot of stress, and which further will increase the cortisol levels and further increase the sugar levels. Okay, this is mainly typical for diabetic. So main thing is to identify the source of infection. If it is a tooth, it has to be extracted under antibiotic coverage. Don't wait for the medical status to improve, then we can go ahead with the treatment. Okay, source of infection has to be removed under antibiotic coverage, along with incision and drainage.
Okay, fine. Thank you. Yeah. Students, if you have any queries to ask Dr. Srikanth, you can directly ask it now. I think there's no queries from students, so no problem. Yeah, Dr. Reno, you can propose the vote of thanks then.
Okay, good evening to all. It is my privilege to propose vote of thanks. On behalf of Department of Public Health Dentistry, I would like to, I take this opportunity to thank Dr. Srikanth for his excellent presentation, which has enlightened our students. Anyway, thank you, Doctor.
Thank you. Thank you very much.
Okay, now I would like to thank Dr. Bentley George, Vice Principal and Head of the Department, for his constant support. Also, I would like to express my thanks to third years and final years, especially the coordinator, Sandra Arun. Thank you all.
Yeah, thank you, Dr. Srikanth. I have couriered the certificate and the memento. You will receive it shortly.
Thank you.
Thank you once again. Thank you, participants also.
Thank you. Thank you, Bentley. Thank you, Dr. Reno. Thank you, Sandra. Thank you all.